Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled Cardiovascular Screening in Pediatric Competitive Athletes.
And this is a topic that really bridges the gap between clinical cardiology and everyday public health.
It absolutely does. And to start this deep dive, I want you to imagine you are handed the keys to a high-performance sports car.
Oh, a nice analogy right off the bat.
Right. We are talking about an elite machine, built for aggressive speed, rapid acceleration, and incredible endurance. Before you even think about taking that car out onto the track to push it to its absolute limits, what is the very first thing you do?
You do a mechanical inspection.
Exactly. You check the engine, you check the brakes, you verify that the underlying systems can actually handle the immense physical stress of high performance. I mean, you would never skip that step.
No, of course not.
Yet, when we look at youth sports, when we watch young, high-performing athletes pushing their bodies to the absolute limit on fields and courts every single weekend, inspecting their engines is still a subject of massive and sometimes highly contentious global debate.
It really is. And it is a tension that sports medicine professionals grapple with daily. Because on one hand, youth sports are universally synonymous with health and vitality.
Right. Getting kids active is the goal.
Exactly. But on the other hand, how do we realistically protect these young athletes from the rare but completely devastating risk of sudden cardiac death? And to really understand the weight of this 2026 study by Miranda Shervashidze, we have to recognize a significant geographical blind spot in the medical literature.
The data desert, right?
Precisely. While the debate on optimal screening models, what tests to run, how often to do them, is truly international, there has historically been a massive lack of data regarding this issue in Eastern Europe and the Caucasus region.
So they were essentially flying blind.
Well, for decades, policymakers in those areas have had to rely on data extrapolated from North American or Western European populations. But genetics, environmental factors, baseline healthcare access, all of these differ wildly across the globe.
Makes sense.
So this study was specifically designed to fill that exact gap, providing region-specific epidemiological data from the country of Georgia. And that is absolutely critical for shaping localized, evidence-based sports safety policies.
Okay, I want to start with the why. Because to the average person or, the average parent listening to this right now who has a kid playing travel soccer, the phrase sudden cardiac death in children is terrifying.
It is the ultimate nightmare for any parent or coach.
It is. But the medical literature, including this very study, consistently categorizes it as a rare event. So if it is genuinely so rare, I have to ask, why isn't a standard doctor's physical enough?
That is the most common pushback we see.
Right, because if you've ever sat in a pediatrician's office filling out that single-page sports physical form for your kid, you know exactly what the standard looks like. They listen to the chest with a stethoscope for 30 seconds, they ask if anyone in your family has fainted recently, and they sign the form.
Yes, the standard clearance.
Why isn't that sufficient? Why do we need to mandate full structural high-tech screenings for kids who outwardly look like the picture of perfect health?
Well, because a stethoscope, for all its historical value in medicine, is fundamentally limited. It relies entirely on acoustic feedback.
Meaning you can only catch what you can actually hear.
Exactly. You are listening for murmurs or irregular rhythms that are loud enough to be heard through the chest wall. But the conditions that typically cause exercise-related sudden cardiac death in youth are incredibly subtle.
They aren't making a lot of noise.
No, they aren't. The study highlights a crucial premise here. A significant proportion of these tragic cases are caused by previously undiagnosed structural or electrical heart abnormalities. And these are not conditions that necessarily make a child feel sick on a day-to-day basis.
So they wouldn't even know something is wrong.
Right. A child with a lethal electrical anomaly might feel perfectly fine sitting in a classroom or even going for a light jog. The anomaly only becomes a fatal vulnerability under the extreme, sustained physiological stress of competitive sports.
When adrenaline is surging.
Yes, when the heart rate is maxed out and oxygen demand is at its absolute peak.
So the standard physical is essentially missing the hidden bugs in the system. To go back to the car analogy, it's like the pediatrician is looking at the paint job and listening to the engine idle in the driveway.
That is a great way to put it.
But they aren't hooking the car up to the diagnostic computer to see what happens to the internal systems when it hits 120 miles per hour on a straightaway.
That captures the limitation perfectly. The resting heart might not show any signs of distress. And that brings us to the methodology of this study. The researchers wanted to find those hidden bugs.
Right, so how did they do it?
They conducted a population-based cross-sectional study in 2025, recruiting 442 competitive athletes. These were kids ranging from 7 to 18 years old, actively engaged in organized sports institutions in the region of Ajara, Georgia.
Okay, so we have 442 young athletes, all actively competing, all presumably feeling fine. How do the researchers actually look inside the hearts of over 400 kids to find issues that a stethoscope misses?
Well, the study details a standardized, multi-layered cardiovascular evaluation.
Break that down for us. What does that actually look like for, say, a 12-year-old walking into this clinic?
It was a rigorous sequential process. First, they didn't abandon the basics. Every evaluation started with a deeply structured medical and family history, followed by a thorough physical examination.
So they still do the baseline.
Always. But then they brought in the advanced diagnostics. Every single participant underwent a 12-lead electrocardiography, or ECG. This involves placing small, sticky sensors on the child's chest and limbs to map the electrical voltage.
And the timing of the waves, right?
Really, the timing of the waves traveling through the heart muscle. They are looking at the precise milliseconds it takes for a signal to move from the upper chambers to the lower chambers.
Let me try to translate that into something a bit more tangible for the listener. The 12-lead ECG, that is basically the researchers bringing in an electrician to check the wiring of a house, right?
That is a very apt comparison.
They are looking at the signals that tell the heart when to beat, making sure there are no short circuits or misfires in that electrical pathway.
Functionally, yes, the ECG is mapping the electrical integrity. Then they layered on the next test, which is transthoracic echocardiography. Right. This uses high-frequency sound waves, ultrasound, to create real-time moving images of the heart. It allows the cardiologist to actually see the thickness of the muscle walls, the size of the chambers, and watch the valves opening and closing.
So if the ECG is the electrician checking the wiring, the echocardiogram is the structural inspector checking the plumbing and the load-bearing walls.
Precisely. They are looking at the physical mechanics to make sure nothing is obstructing the flow. And they added one more crucial layer to this, a detailed anthropometric assessment.
Anthropometric, meaning body measurement.
Yes, but this isn't just taking their height and weight. It is calculating the child's exact body surface area, or BSA.
Why does body surface area matter so much when you are looking at a heart?
Because an 18-year-old elite athlete's heart is naturally enlarged from years of training. It is a healthy physiological adaptation called athlete's heart.
Oh, sure.
But a 7-year-old's heart is obviously much smaller. Furthermore, if you have a 14-year-old who just grew 4 inches over the summer, their heart is rapidly remodeling to pump blood through a suddenly larger body.
I see where this is going.
Right. If a cardiologist doesn't scale the ultrasound measurements to the child's exact current body size, they run the risk of misdiagnosing a naturally enlarged, healthy athletic heart as a dangerously diseased one.
That makes total sense. You need to know the dimensions of the chassis before you can judge if the engine is the right size.
Exactly.
Okay, now let's get to the findings. You run this massive diagnostic battery on 442 young athletes. Reading the results, the numbers immediately jump out. Out of the 442 kids, 13.1%, which is 58 individual athletes, had some kind of cardiovascular abnormality.
Yes.
I have to say, if I'm a parent and I hear that 13% of kids have a heart abnormality, I am instantly panicking. I mean, that sounds incredibly high.
It does sound alarming at first glance, which is why context is absolutely critical here. Finding an abnormality does not equate to finding a life-threatening crisis.
Okay, that is reassuring.
The study clearly delineates that the vast majority of these 58 cases were low-risk, minor structural valvular findings. For instance, they might find a tiny benign leak in a valve, or a slight physical variation that a cardiologist might want to monitor every few years.
But it doesn't put the child in danger.
No, it absolutely does not put the child at risk of a catastrophic event on the soccer field.
So they aren't pulling these kids out of the game. It is just a note in their medical file.
Correct. But then we look at the other end of the spectrum, the high-risk group. The researchers found that 0.45% of this cohort, specifically 2 out of the 442 athletes, or walking around with severe high-risk conditions.
Wow. 2 kids out of over 400.
Yes, they identified one case of hypertrophic cardiomyopathy and one case of Wolff-Parkinson-White syndrome.
Let's dig into those 2 specific diagnoses because I think they perfectly illustrate why running both the electrical test and the structural test is so vital.
They really do.
Let's start with hypertrophic cardiomyopathy, or HCM. What exactly is happening in the heart of a kid with HCM?
HCM is primarily a structural issue. At a cellular level, the heart muscle cells are physically disorganized. Instead of lining up neatly to contract together, they are in disarray, causing the heart muscle wall to abnormally thicken.
Thicken where, exactly?
Usually in the septum, which is the wall dividing the left and right sides of the heart. As the wall grows inward, it physically restricts the size of the pumping chamber.
So the tank holding the blood gets smaller because the walls are too thick.
Yes. And worse, that thick muscle can actually block the exit route when the heart squeezes to pump blood out to the body. At rest, the child feels fine.
Because the demand is low.
Exactly. But during a sprint, when the body is screaming for oxygen, the heart beats faster and harder, the obstruction worsens, and the heart physically cannot pump enough blood to sustain the brain and body.
That is terrifying.
It is a leading cause of sudden cardiac death in athletes. And it is exactly the kind of thick wall problem the echocardiogram is designed to catch.
And what about the second diagnosis, the Wolff-Parkinson-White syndrome?
Wolff-Parkinson-White, or WPW, is completely different. It is an electrical issue. Individuals born with WPW have an extra, abnormal electrical pathway connecting the upper and lower chambers of their heart.
So essentially a rogue electrical bridge.
That is a great way to describe it. Normally, the heart's electrical signal pauses for a fraction of a second at a specific gatekeeper node before telling the lower chambers to pump. In WPW, the signal can take the rogue bridge, completely bypassing the gatekeeper.
Creating a short circuit.
Exactly. Under the stress of intense physical activity, that short circuit can cause the electrical signal to get caught in a continuous rapid loop. Instead of an organized beat, the heart begins to beat at an incredibly chaotic, dangerously rapid rate.
Which means it isn't pumping effectively anymore.
Right, sometimes degrading into ventricular fibrillation where the heart just quivers and pumps no blood at all. That is the faulty wiring problem, and it's what the ECG catches.
Both conditions are silent, both are lethal under the stress of sports, and both were discovered in kids who thought they were perfectly fine.
That is the core takeaway of the clinical findings.
Okay, finding those 2 kids is an incredible clinical victory. But here is where we need to look at the harsh realities of public health policy, right? The study highlights a specific metric called the number needed to screen, or NNS.
Yes, a very important statistical concept.
In this cohort, the NNS was 221. That means you have to put 221 kids through this entire multi-layered evaluation, the history, the physical, the ECG, the ultrasound, just to find one high-risk condition.
That's correct.
Let's be real here. I can hear healthcare administrators groaning from here. Screening 221 kids to find one issue sounds like a massive drain on resources. I mean, is it really worth buying dozens of ultrasound machines, hiring specialized technicians, and booking up cardiologists just to catch one kid?
Well, it is the defining debate in sports cardiology. If you look at it strictly through the lens of short-term financial outlay, it is an expensive endeavor. But public health operates on a population scale, and it requires us to measure the cost of inaction. What is the cost, both financially to the healthcare system and emotionally to a community of a healthy 15-year-old collapsing and dying on a basketball court?
The emotional cost is undeniable. Nobody wants to see a tragedy.
Exactly. The loss of a child is an immeasurable tragedy, and preventing even one event is highly significant from a system-level reflection.
But what about the cost of false positives? I mean, if you screen 221 perfectly healthy kids with highly sensitive equipment, aren't you bound to flag a few innocent heart murmurs? Ground those kids unnecessarily and cause a ton of panic for their parents while they wait weeks for a follow-up appointment.
That is a very valid critique, and it is exactly why the multi-layered approach used in this Georgian study is so important. When you only use an ECG, the false positive rate can be uncomfortably high.
Because electrical signals can be tricky to interpret.
Right, especially in young athletes. But when you immediately pair it with an echocardiogram, as they did here, the ultrasound often clears up the electrical ambiguity right there in the clinic.
Ah, so it acts as an immediate second opinion to verify the threat.
Yes. The dual approach significantly reduces the false alarms that lead to unnecessary psychological distress or the unjust disqualification of a healthy athlete.
That makes a lot of sense.
And beyond that, this NNS of 221 provides something the Caucasus region desperately needed, a baseline reality. Policymakers in Georgia can't build budgets based on guesses or data from completely different healthcare systems.
I need their own math.
Exactly. Knowing that the local yield is one high-risk case per 221 athletes allows a government to accurately calculate the required clinical capacity, project the budget for equipment, and design a phased rollout that matches their infrastructure. It turns an abstract philosophical debate into a concrete mathematical plan.
Which perfectly brings us to the global impact of this local study. We are talking about 442 kids in Ajara, Georgia. But what happens when we take these findings and hold them up against the rest of the world?
Well, the researchers found that the epidemiological patterns in their Georgian cohort, the 13.1% overall abnormality rate, and the 0.45% high-risk detection rate are remarkably consistent with established international screening cohorts.
Really? Even compared to places with massive, long-standing programs?
Yes, like Italy, for example. It proved that the underlying physiological vulnerabilities of the human heart present with the same statistical frequency regardless of geography.
So it's like discovering that a standardized safety blueprint actually holds up no matter where you are building. The structural and electrical flaws in the human heart react the same way, whether that kid is playing soccer in London, running track in Chicago, or competing in a wrestling tournament in Georgia.
The pathology doesn't care about borders. However, the researchers are careful to outline the methodological limitations of their own work.
What kind of limitations?
Because this is cross-sectional data, meaning it's a snapshot in time of these 442 athletes, it cannot definitively prove that this specific screening protocol reduces overall mortality rates over the span of decades.
Right. To prove a long-term reduction in sudden cardiac death requires longitudinal studies, right? Tracking these cohorts for 10 or 20 years to document survival rates.
Exactly. They proved they have the right tools to find the hidden vulnerabilities, but a cross-sectional study doesn't track those kids into adulthood. But what it absolutely does provide is proof of concept for the region. It moves the conversation for emerging sports systems from should we screen to how do we best implement this screening with the resources we have.
So what does this all mean for you, the listener? Let's recap the ground we've covered in this deep dive. We explored the vital necessity of deep, multi-layered cardiovascular screening because, as we learned, standard physicals simply cannot see through the walls of the heart to catch the electrical and structural anomalies hiding within. We looked closely at the core findings from the 442 youth athletes in Georgia, discovering that while 13% had minor abnormalities, it was the discovery of the high-risk conditions, the kids unknowingly walking around with hypertrophic cardiomyopathy and Wolff-Parkinson-White syndrome, that represent the undeniable life-saving potential of this work.
The clinical yield is clear.
And we examined the crucial yet debated institutional implications of screening 221 athletes to catch one high-risk case, recognizing it as an invaluable blueprint for local policy and resource allocation.
It is a study that perfectly bridges the gap between individual clinical care and broad public health strategy. By establishing that the prevalence of these hidden conditions in Georgia perfectly mirrors international data, it empowers local institutions across the region to finally build robust, evidence-based safety nets for their young athletes.
I want you to think about the youth sports leagues in your own community. Think about the soccer fields on Saturday mornings, the high school basketball gyms on a Friday night, the summer track meets. Think about the incredible physical effort those kids are putting out. We prepare the fields, we buy the absolute best protective gear to prevent joint injuries, but are we truly inspecting their engines?
It's a sobering thought.
What unseen medical safety nets, or lack thereof, are currently supporting them in your town?
As portable diagnostic technology becomes cheaper and more accurate, it is a question every school board and sports league will eventually have to answer.
Which brings us to a final thought for you to mull over as you go about your day. Think about how rapidly sports culture can change when safety is on the line. Just 10 or 15 years ago, a teenager taking a hard hit to the head on the football field was often told to just shake it off and get back in the game.
Yes, the old standard.
Today, mandatory strict concussion protocols are universally accepted and rigorously enforced. The culture completely shifted to protect the brain. This study proves unequivocally that structural and electrical screenings are highly effective at catching the hidden dangers that threaten young hearts.
The data is undeniably there.
So, as ECGs and echocardiograms become increasingly portable, faster, and more accessible, we have to ask ourselves, Are we on the verge of another massive cultural shift? Will we soon see a future where a full cardiac scan is just as routine and just as mandatory as signing a permission slip or passing a concussion baseline test before a child is ever allowed to join a sports team?
It is a future worth striving for.
Thank you for listening to the GMJ podcast. For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.